Hello and welcome to the second part of a three-part CME-accredited video discussion entitled Community Oncology, Clinical Debates in Breast Cancer, with a focus on advanced hormone receptor-positive breast cancer. I'm Dr. Harold Burstein, an Associate Professor of Medicine at Harvard Medical School, and I'll be your moderator for this educational activity. I'm delighted to be joined today by Dr. Stefan Gluck, Distinguished Professor at the Sylvester Comprehensive Cancer Center at the University of Miami. Welcome and thanks so much for joining me today.
Thanks for having me.
The learning objectives for segment 2 of our program are such that upon completing the accredited video segment, you'll be better able to apply the optimal sequencing of current and novel agents used in the treatment of advanced ER-positive breast cancer, identify current, emerging, and investigational therapeutic approaches for first-line hormone receptor-positive breast cancer, including combination therapies with endocrine treatment and the use of targeted drugs, and be able to describe the safety, efficacy, and tolerability of novel and emerging therapies that have been reported in recent clinical trials, including the clinical implications of those studies. So, Stefan, I'd like to begin our second debate as well with a case that really asks the question about what's the optimal frontline therapy for a patient with advanced hormone receptor-positive breast cancer. Our case here is of a 47-year-old premenopausal woman who had been diagnosed with metastatic breast cancer. She had been evaluated because of nonspecific changes in the right breast, which had prompted an MRI evaluation. At the time of the MRI evaluation, there were extensive architectural abnormalities noted in an area exceeding 5 centimeters in size within the breast, and a breast biopsy revealed invasive lobular carcinoma, grade 2, that was estrogen receptor positive, progesterone receptor positive, and HER2 negative. She underwent a mastectomy and axillary node dissection and was found to have metastatic lobular carcinoma in 5 out of 13 axillary lymph nodes, including foci of extranodal extension. Staging CAT scans were then performed, and they showed suspicious areas in the bone, including as well as multiple sub-centimeter pulmonary nodules and an enlarged mediastinal lymph node. She underwent a bronchoscopic evaluation of a hilar lymph node that showed metastatic breast cancer consistent with her lobular tumor. So the questions for this case really focus on initial management of premenopausal women, and then I think we'll switch to discussing initial management of postmenopausal women. Obviously, this patient is naive to hormone therapy. How would you approach a therapeutic decision in this young woman who has newly diagnosed metastatic disease with some bone lesions, some sub-centimeter pulmonary abnormalities, and mediastinal lymphadenopathy?
Well, as we always do, we drive our treatment by the cancer, but also, and more importantly in this case, by the patient. Patient means how is her performance status, what's her age, what's the menopausal status. And as we have seen in the presentation of the case, she does not have many symptoms. There was just more or less coincidentally findings in the breast, the lymph nodes, and mediastinum, as well as in the lung. So she is really almost, maybe completely symptom-free. So our goal will be around this. We will not give her treatment that will induce toxicity and decrease her quality of life. Why? Because her disease is incurable. So we want to maintain her highest quality of life and prolong her life as much as possible.
So my suspicion is that in a case like this, before she'd had the staging workup, she had already been expecting adjuvant chemotherapy. She's a premenopausal woman with multiple positive nodes, and now you're going to come back and say, oh, we actually don't need the chemotherapy, we're just going to move on to hormone manipulations. That's often a challenging conversation.
Exactly. The false perception in the community is that chemotherapy being toxic and therefore perceived as very effective is wrong. In particularly lobular cancer, ER, PR positive, HER2 negative, and that's exactly what this woman was diagnosed with, actually endocrine treatment is more effective than chemotherapy.
So she's premenopausal. Does that affect the choices of treatment that we would give instead of if she were postmenopausal? And in particular, do we want to shut down her ovarian function?
Yes, both. Her treatment is very limited as a premenopausal woman to more or less tamoxifen or ovarian suppression. All the other compounds have been tested and approved in a postmenopausal setting. So as we progress with our treatments, the ultimate goal will be, in order to prolong her survival, also making her menopausal and not only improving an outcome with this alone, but also having a number of additional compounds available for her that are not effective in the premenopausal setting.
So in concrete terms, I would typically offer a patient such as this ovarian suppression, usually with GnRH agonist therapy, in combination with tamoxifen. There were some older studies going back to the 80s and 90s that had looked at ovarian suppression alone or tamoxifen or the combination, and in most of those studies the combination yielded an improvement in progression-free and ultimately overall survival. Would that be a similar approach?
Absolutely the same. I would also not choose immediate BSO, bilateral salpingo-oophorectomy, so removing the ovaries, because it's a final decision. And with the LHRH agonist, you have a potentially reversible situation, so the patient can get at least mentally get ready for the menopausal status.
Though it's very unlikely you would ever want her to recover ovarian function. And one of the points I make to our fellows is that, you know, endocrine therapy for advanced breast cancer is really, as you said, all about postmenopausal disease. So the first thing you do is you end up putting the patient into menopause, and then you play out all the treatments. Before we move on to talking about postmenopausal, I want to ask you about two particular variants in cases like this that come up. Let's say she had not had the breast surgery, but she was found to have metastatic disease. Would you recommend a mastectomy?
So it's a very controversial topic, and there are, of course, no randomized prospective studies, but there are, to my knowledge, at least two large cohort studies. One is from the MD Anderson, and the other one is from Switzerland and Europe, and they both have about the same message. If a patient has been diagnosed with stage 4 breast cancer, the mastectomy or the removal of the primary tumor is beneficial for long-term outcome. Not necessarily immediately, but soon after diagnosis. I
would only revise that to say those women who get a mastectomy seem to do better, and how much of that is clinical selection and judgment is always hard to know. In a case like this, where a patient might do well for years and years and years, she's treatment naive, the temptation would be to offer that mastectomy, but whether that really changes the natural history, I'm still a little unclear about in my own mind.
And that's the weakness about the cohort study, which I mentioned. Randomized prospective study do not exist.
So let me ask you one more variant on a case like this. Let's say she had only an isolated metastatic focus. So she'd gotten a staging workup, there was a pulmonary nodule, it was surgically excised, it represented metastatic breast cancer, but there's no other evidence of disease. Would you treat her differently?
Well, that's a very interesting question, because
I didn't want to ask you the dull questions.
I know, yes, and I like those, of course. It is called oligometastatic disease, and in large series, oligometastatic disease, actually, they do better. So I would treat this patient aggressively.
So then you would use an adjuvant approach or a curative early stage
approach.
Approach.
And I would call it curative, because in the back of our minds we know it's not. But we may increase the disease-free, progression-free survival quite substantially.
That would be our approach as well. So we extend that to patients who have an isolated pulmonary nodule, an isolated bone lesion where you might be able to irradiate it or things like that. Well, now let's again shift the dialogue and think about a postmenopausal woman, either a woman who never had adjuvant endocrine therapy because she was a de novo presentation, or who might have had adjuvant therapy many years ago and then was being followed expectantly and had a later recurrence, something we're increasingly seeing because of the effectiveness of earlier use of endocrine therapy. How would the dialogue be different if this patient was already postmenopausal when thinking about a first-line treatment choice?
Well, we have so many choices, and that's the beauty, if I may say, about such a scenario. Starting with tamoxifen that we had for pre and postmenopausal, we now have the choice of aromatase inhibitors. And I'm old enough to remember that we used aminoglutamide, which was discovered only 2 years after tamoxifen. Very toxic, not so effective, but
toxic
still effective.
Because it had more adrenal suppression as well as aromatase in the ovary.
Indeed, it's the first generation of AIs. In the meanwhile, we are lucky enough to have 3 second and third generation AIs, which are oral drugs, very well tolerated. There are very few, sometimes significant, but few side effects, and they can and should be used sequentially. Additionally, more recently, fulvestrant, a estrogen receptor downregulator, has been discovered and used and tested in many, many studies, being very effective in postmenopausal women, maybe in premenopausal, but studies have been done only in postmenopausal women. So the scenario is improving. Of course, we should not forget old megestrol acetate. It's still a drug that is effective. We are more, and our younger colleagues remember it more like a appetite enhancer, but it is a very effective anti-cancer breast cancer drug for estrogen-positive breast cancer.
It's a really good point. You know, most of these therapies, when they've been studied, are actually pretty comparable to one another. And in the older literature, megestrol acetate was essentially as effective as tamoxifen.
Yes.
Tamoxifen had a somewhat easier side effect profile. You tend not to get the withdrawal vaginal bleeding. You tend not to get the breast swelling and weight gain. And there's a lower risk of thrombosis and things. In metastatic disease, comparing the aromatase inhibitors and tamoxifen in treatment of postmenopausal women, the results are pretty similar. A couple of the studies maybe showed a small advantage for the AIs, but again, remarkably similar in terms of their overall efficacy. So there really are a lot of choices, and sometimes I think we sort of jump too quickly, perhaps, to the latest and the newest and greatest things. Having said that, let's jump quickly to the newest, latest, and greatest things, because there has been some new studies looking at particularly a couple of specific questions. One is in a woman who has not previously had an aromatase inhibitor. There was a study that compared AI therapy up front versus fulvestrant therapy up front, the so-called FIRST trial. What were the results of that study?
Well, to summarize in a half a sentence, these compounds, as tested on a study, are completely equivalent in outcome. Slightly different mode of action, slightly different mode side effect profile. One is oral, the other one is given intramuscularly every 4 weeks, and it is a big needle and it hurts because it's a pretty big volume, and yet in between the patient can forget everything else. So it is about quality of life again rather than anything else. But the dose was the old dose of 250 fulvestrant.
So how important is dosing for a fulvestrant? I know that that question's been looked at more recently, and I think it was the CONFIRM trial that compared 500 milligram dosing versus 250.
Yeah, this is significant, albeit not huge, but significant advantage to the higher dose. The higher dose means 2 injections. Usually we do 1 on each side, and it is pretty painful, again, as I said before, but it disappears with less than 24 hours. And both response rates and time to progression is significantly improved with a higher dose.
So it looks like, and then that led FDA to change the labeling for fulvestrant. So fulvestrant now is a 500 milligram drug, and that's our standard practice as well. This past year, there's been a lot of debate about whether to use combinations of endocrine therapy. We talked in the premenopausal setting about ovarian suppression and tamoxifen, but in postmenopausal women, the discussion has been more of an aromatase inhibitor given with or without fulvestrant. There have been 2 studies, and they reached different results. That's not so helpful for community oncologists to hear. Let me mention first the FACT trial, which was a study presented and now published by Jonas Berg, which was the aromatase inhibitor anastrozole with or without fulvestrant. And that showed absolutely no difference with respect to progression-free or overall survival. But then at San Antonio this past year, we saw the results of SWOG 0226, which was just published in the New England Journal of Medicine. The exact same design, anastrozole plus or minus fulvestrant, the exact same dosing of the drugs. That was a positive study for progression-free survival. Explain that to me, please.
Well, I think it gives us 2 or 3 lessons. Lesson number 1, one study alone often doesn't suffice. You need a confirmatory study. And we saw it here. And the confirmation here was not one. Actually, it confirmed, not that it's equivalent, but it's better. The second lesson is, statistics is one thing, and indeed, there's statistical advantages, both the response rates and particularly response duration and time to progression in favor of the combination arm. But if you look at the magnitude, which means the clinical benefit, the real day-to-day management issue, it's a month or 2. So does it really matter? I would argue not. I would argue to adding each of the drugs individually sequentially gives you more than big response and a little bit of time to progression.
Well,
Significant.
The other interesting thing about the 2 studies was they were somewhat different patient populations. So the SWOG trial, it seemed like most of the benefit was in these really endocrine naive patients who'd never received treatment before, whereas in the FACT trial, almost all those patients had previously had some tamoxifen therapy. So I want to help our audience understand in concrete terms at the moment, you are or you are not using combinations of aromatase inhibitors and fulvestrant.
I am not.
I'm not either, though there is a 3rd study out there, the SOPHIA study, so that will be the ultimate tiebreaker, I suppose.
But I still would think if the clinical benefit is so minimal, even if this were a positive study, I still would argue for the single sequential use.
Well, let's go back to our case discussion, and this was a premenopausal woman with newly diagnosed metastatic disease. The initial endocrine therapy of choice could be tamoxifen, ovarian suppression and tamoxifen, ovarian suppression with an AI, or ovarian suppression with a fulvestrant treatment. And your choice would be?
Probably C, which means ovarian suppression, and I think we discussed it jointly in the same way with tamoxifen. And let me add one sentence. Ovarian suppression with aromatase inhibition in a premenopausal woman is not standard of care. And it may become one day, but today data do not support it, and it's dangerous to assume that ovarian suppression with LHIH agonist makes the patient really menopausal, hence to make the aromatase inhibition fully effective.
That's a great point. We've all seen in our practices, a handful of patients who just don't functionally suppress with the GnRH agonist. Yeah, so C would be my choice as well, based on those older randomized trials.
Yes.
Let me just shift it and say if the patient was now postmenopausal, so we're going to take the ovarian suppression out of the equation, I'll give you choices of tamoxifen, an aromatase inhibitor, fulvestrant, or the combination. We already dealt with the combination. So which of these in practical terms, tamoxifen, an AI, or fulvestrant, would you pick first out of the box?
I would pick simply an AI, and doesn't matter which of the three. And it's not necessarily the efficacy, it's particularly the tolerability and side effect profile.
Very convenient, very easy, and portable. And for women who are settling in for long runs, that makes such a big difference. Well, let me try and give you the key takeaways from this segment on the optimal first-line use of therapy for a patient with advanced ER-positive breast cancer. As you've heard, there are a variety of treatment options. Chuck Vogel, your Florida colleague, used to say there were 11 different kinds of anti-estrogen treatments. I've never taken a patient through 11, but there certainly are a lot. In concrete terms, for a premenopausal woman, it's going to be ovarian suppression, most likely then with tamoxifen. For postmenopausal patients, there are options including initial use of an aromatase inhibitor or tamoxifen or fulvestrant. The role of combining the anti-estrogen therapies at the moment is still a bit unclear. Perhaps there's a signal of some modest benefit in the absolutely endocrine naive populations, but as you mentioned, the absolute differences were actually pretty small, and I think single agent sequential therapy would be a perfectly reasonable option for most women as they embark on initial therapy for ER-positive breast cancer. That concludes the second part of our three-part series on management of advanced estrogen receptor-positive breast cancer. Stefan, it's a pleasure again to have done this with you. Thank you to the audience for joining us for this valuable activity.